Hi, my name is Dr. Samuel Latham, and this is my ophthalmology teaching presentation for Lewisham Paediatrics A&E department. In this presentation, we will cover the acute red eye, acute vision loss, causes of ophthalmic asymmetry, and periocular pathologies. We will then quickly run over pediatric eye assessments and some take-home messages. First, let's cover the acute red eye. The most common presentation to pediatrics A&E is conjunctivitis. There are three different types: bacterial, viral, and allergic. The clues that help us differentiate them from one another are the discharge, which is purulent in bacterial, and the associations. The treatment for bacterial and viral conjunctivitis is topical chloramphenicol. The reason we give it in viral is because we want to avoid superadded bacterial conjunctivitis. In viral, we also advise isolation, so not sharing towels, etc. And in allergic, we advise sodium chromoglycate drops, which are available over the counter. A condition to be aware of is ophthalmia neonatorum, which is conjunctivitis within the first 30 days of birth. Common organisms are gonorrhea and chlamydia. Gonorrhea tends to be more aggressive with more discharge. It is important to send an urgent eye swab and to speak with microbiology. Generally speaking, the treatment for gonorrhea is IV cefotaxime, whereas the treatment for chlamydia is oral erythromycin. This is a potentially sight-threatening condition, so if you're unsure about anything, escalate to a senior. Childhood glaucoma is caused by an increased pressure in the eye that is due to a lack of aqueous drainage. Symptoms include severe pain and nausea. Signs include fixed mid-dilated pupil, which you can see with this child's left eye. There may also be some associated redness, blurred vision, and haziness. This is an ophthalmic emergency, therefore do not hesitate to contact ophthalmology if you suspect glaucoma. Ophthalmology may request you to initiate some treatment. Initial treatment is usually drops, of which there are many types that can be used in combination. First line is usually a prostaglandin analog, such as latanoprost. Second line is usually a beta blocker, such as timolol. Corneal abrasions are frequently seen in pediatrics A&E. Causes commonly include foreign bodies, trauma, and inserting or removing contact lenses. Signs include pain, redness, tearing, photophobia, excessive blinking, or holding the eye closed. If the abrasion involves the central part of the cornea, vision could also be temporarily affected. Diagnosis is reached with fluorescein staining. As you can see in the photograph, an abrasion will turn green in cobalt blue light. Treatment involves removing the foreign body if present. Most corneal abrasions slowly self-heal over several days. However, because the surface damage makes the eye more susceptible to infection, abrasions may require antibiotic eye drops or ointment. We should also offer treatment advice to take simple analgesia, avoid rubbing or touching the eye, and to not wear contact lenses until the eye is completely healed. Confirmed corneal abrasions should be discussed with ophthalmology. There are some other causes of an acute red eye that are worth quickly mentioning. Photograph A is an example of uveitis, which is HLA-B27 associated. Therefore, diagnostic clues include a past medical history of ankylosing spondylitis, IBD, sarcoid, TB, or Lyme's disease. In uveitis, the iris goes into spasm, and this causes a small pupil, or sometimes the iris gets stuck to the lens, which causes an irregular pupil, as you can see in the photograph. Photograph B is an example of keratitis, which is a corneal infection. This usually manifests as an ulcer, which would appear on fluorescein staining. Photograph C is an example of scleritis, and photograph D is an example of episcleritis. In scleritis, the patient will have deep boring pain and potentially a blue patch, which represents thinning of the sclera. Whereas in episcleritis, the pain is less severe and there are no blue patches. Episcleritis is something that we should be able to recognize and manage. In most patients, episcleritis recovers on its own and may not need any treatment. However, the symptoms can be relieved using artificial teardrops. Now let's cover acute vision loss. Vitreous hemorrhage is detectable with ophthalmoscopy. The most common cause in children is trauma. The lower image on this slide is an example of shaken baby syndrome. Vitreous hemorrhage can lead to retinal detachment, which is an ophthalmic emergency, and also amblyopia, which we will cover later in this presentation. Treatment is usually conservative, but may require surgical vitrectomy. If you suspect vitreous hemorrhage, you should speak with ophthalmology. Who may want to perform a B scan, which is a type of ultrasound to check if the underlying retina is flat. You should also definitely think about safeguarding. Retinal detachment is also detectable with ophthalmoscopy. Symptoms include vision loss, which may be described as a closing curtain. The patient may also describe flashing lights and floaters. Predisposing factors include trauma, short-sightedness, and retinopathy of prematurity. We know that retinopathy of prematurity occurs when oxygen therapy is used in premature babies due to the underdevelopment of their lungs. This oxygen causes disorganized growth of retinal blood vessels, which may result in scarring and retinal detachment. Retinal detachment is an ophthalmic emergency, so don't hesitate to speak with ophthalmology. Treatment for this is surgical vitrectomy. Orbital compartment syndrome is where elevated intraorbital pressure results in impaired perfusion of the optic nerve and globe. Signs therefore include a decreased visual acuity, afferent pupillary defect, and elevated intraocular pressure. It is commonly caused by retrobulbar hemorrhage or infection, and so clues in the history might be recent trauma, a coagulopathy, recent surgery, preseptal or orbital cellulitis, and acute or chronic sinusitis. There is a risk of permanent vision loss if not correctly treated rapidly. Ideally, this should be in the first 2 hours. Treatment is lateral canthotomy and inferior cantholysis. This is a bedside procedure that restores blood flow to the retina and the optic nerve. Orbital compartment syndrome very rarely occurs. However, if it does occur, you should contact ophthalmology and escalate to a senior. It is also worthwhile contacting the on-site surgical team, which at Lewisham is ENT. Next, we have causes of ophthalmic asymmetry. Strabismus, also known as squint, is a misalignment of the eyes. This can be demonstrated by the Hirschberg test. In the photograph, you can see a pen torch is being held away from the child's midline. The reflection lies centrally within the child's left pupil, but medially to the child's right pupil. This confirms that the child has a right-sided exotropia rather than a left-sided esotropia. Treatment for strabismus is lenses, vision therapy, or surgery. Amblyopia, also known as lazy eye, is a unilateral reduction in visual acuity secondary to understimulation of the visual cortex. So essentially, the brain fails to process inputs from one eye and over time favors the other eye. Strabismus is one of 3 main causes of amblyopia. Amblyopia is the #1 cause of preventable vision loss in developed countries, and treatment is often just patch therapy. If you suspect either of these pathologies, you should perform visual acuity testing monocularly in each eye and binocularly, then contact ophthalmology. Retinoblastoma is a rare cause of ophthalmic asymmetry. Around 50 to 60 children are diagnosed each year in the UK. 40% of this is in the first year of life, and it is very rarely seen in children older than 5. Good prognosis depends on early recognition. Children with a family history of retinoblastoma should receive screening from birth to the age of 3 years. This involves regular eye examinations under a general anesthetic. The frequency of this depends on the determined risk level. Signs and symptoms include leukocoria, which you can see in the higher photograph, strabismus, redness, exophthalmos, and poor visual acuity. Suspected cases should have a 2-week wait referral to ophthalmology. Moving on to periocular pathologies. Periorbital cellulitis is a pathology to be cautious of. This is because it can progress to orbital cellulitis, which is a surgical emergency. The complications of orbital cellulitis include loss of vision, abscess formation, venous sinus thrombosis, intracranial infection with subdural empyema, and meningitis. The red flag signs and symptoms are painful or restricted eye movements, visual impairment, a relative afferent pupillary defect, loss of colour vision, specifically loss of red and green discrimination, or if the patient is a neonate, in which case we need to send swabs. In mild cases, the treatment as per microguide is oral comoxiclav or clarithromycin if penallergic for 10 to 14 days. In moderate to severe cases, IV comoxiclav, CT brain and orbits, and ENT, ophthalmology, and microbiology input. If radiology confirms orbital involvement, we should replace IV comoxiclav with IV ceftriaxone and metronidazole. However, please confirm this with the relevant specialties. Here we have three pathologies that are commonly mistaken for one another. Blepharitis is inflammation of the eyelids, causing the eyes to feel sore and gritty and appear puffy and red. A stye, also known as a hordeolum, is caused by an infected eyelash root. It is very painful and often appears at the eyelid's edge. A chalazion, also known as a meibomian cyst, is caused by a clogged oil gland and is a non-painful bump that usually develops further back on the eyelid. The treatment for all three is eyelid hygiene, warm compressors, which increase drainage of the affected gland, and gentle massage, which helps to express the trapped contents. If acutely inflamed, prescribe chloramphenicol ointment 3 times a day for 1 to 2 weeks. A common complication of these pathologies is dry eyes, and for this we can advise artificial tears. If conservative therapy fails, then we should seek advice from ophthalmology. Now, to refresh your memory, we will quickly run through eye assessments. During external examination, you should aim to recognize if the child is in pain, has a red eye, asymmetry, lymphadenopathy, any discharge, or if the child appears to be itching. When a child presents with ocular trauma or a suspected corneal abrasion, you should attempt fluorescein staining and eyelid eversion. A pupil's assessment should determine if each pupil is equal in shape and size and reactive to light. To quickly recap, causes of a dilated pupil include glaucoma, trauma, and ocular compartment syndrome. There are also some other causes such as Horner syndrome, raised intracranial pressure, and poisoning. Causes of an irregular pupil include penetrating injury and uveitis. For red reflex, you should use a darkened room. An ophthalmoscope is focused on each pupil individually from approximately 1 foot away, and then both eyes are viewed simultaneously at approximately 3 feet away. The red reflex seen in each eye individually should be bright reddish yellow, or light gray in darkly pigmented brown-eyed patients, and identical in both eyes. Dark spots in the red reflex, a dull red reflex, or presence of white reflex are all indications for a referral to ophthalmology. Visual acuity is determined in children older than 3 by using a Snellen's chart. Remember to write the actual value to allow for future comparisons. In younger children, visual acuity is determined by their ability to fix and follow. In other words, can each eye fixate on an object, maintain fixation, and then follow the object into various gaze positions. The assessment should be performed binocularly and then monocularly. If fix and follow is poor after 3 months of age, a referral for more formal vision assessment is advisable. It is also worth noting that nystagmus in this age group might be a sign of poor vision. Eye movement assessments help us to detect ophthalmoplegia, which might be caused by strabismus, trauma, periorbital cellulitis, neurological disorders or muscular dystrophies, and retinoblastoma. Detection of ophthalmoplegia warrants an ophthalmology referral. Visual fields assessments can help us to detect pathologies such as glaucoma, retinal detachment, retinoblastoma, infection, raised intracranial pressure, and head trauma. Ophthalmoscopy is another crucial aspect of eye assessments. On the right, we have a normal retina, and on the left, we have pathologies in which we would at least be able to recognize that the retina does not look normal. This includes hemorrhages caused by trauma and shaken baby syndrome, retinoblastoma, retinal detachment, papilledema, which is a sign of intracranial hypertension or tumors, optic atrophy, CMV retinitis, and toxoplasmosis. We know that children do not always want to cooperate. This is especially true for younger children. So here we have a guide which suggests the aspects of eye assessments that we should be attempting in 2 age groups. In children from birth to 4 years of age, we should be attempting external examination, pupil examination, red reflex, eye movements assessment, and we should also consider fluorescent staining. In children aged 4 years and older, we should be attempting 1 through 5 plus visual acuity measurement, visual fields assessment, fundoscopy, and we should also consider eyelid aversion. So what are the take-home messages? Use the ophthalmology equipment toolbox, which should include everything that you need to perform a thorough eye assessment. Examine both eyes, not just the pathological one. Complete a thorough vision assessment. With uncooperative children, you should ask the GP to make a second attempt. When you have infection in neonates, send an urgent eye swab. And if you are ever unsure, discuss with a senior or ophthalmology. Thank you for listening to this presentation. I would be very grateful if you were able to scan the QR code and leave some feedback. Thank you very much.